meeting on the unceded lands of the Wurundjeri people of the Kulin Nation. And this is a really well-timed seminar, I think, because we've just come out of NAIDOC Week, and tomorrow is World Environment Day. And of course, the Australian environment has traditionally been best understood by its Indigenous people. And just yesterday, Wayne and Matt and I went on an Indigenous tour of the Botanic Gardens that helped bring those ideas together. And so I think we have a seamless movement from that into the greatest threat to the environment, which is global heating, which is what Ollie's going to talk about. So it's my pleasure to introduce Ollie Jay. That's him there. You'll see more of him in just a second. Ollie and I met through the fact we're both on Minderoo's Lethal Global Humidity Council or something like that, which is funded by Minderoo, and we meet and discuss the impacts of climate change on human health and how best to go about understanding and mitigating those impacts. And what Ollie has really focused on is heat stress and its impact on humanity. And he's Professor of Heat and Health at the University of Sydney. He directs the Heat and Health Research Centre there. But he's involved in, for example, with Google in trying to coordinate automated heat warning alerts. He's involved in extreme heat protection in a number of sporting and other contexts where the risk is more extreme than it is in the normal population. And works with groups organised by Lancet Global Health, for example, to try and bring these things to the attention of the world and help mitigate them. We've got beginning to have an interest in what he might consider a more boring aspect of this at WEHI, which is the mechanistic impact of increased ambient temperature on, not on the extreme heat stress that he looks at, but lower level changes. And we've just had funding from the Galley family to get some terrific kit here, which Claire Weed and I and others will be working, which allows us to moderate heat, humidity, and have an understanding of metabolism in mice at different temperatures. So you'll hear more about that from me and Claire and others later. But what we really want to hear about is a genuine international expert in this area to mark World Environment Day. Ollie, over to you.
Thank you for that introduction, Ken. I've got, I think, 35 minutes, so I'll get right into it. I'll start off with this figure here, which I think most people will have seen either this exact figure or a version of it. And it's, when you kind of sit down and go through it, it's pretty confronting stuff. So we live in an era of climate change. That is undeniable. And this is best illustrated by this figure, which shows how average global temperatures have changed since the end of the 19th century. So these are all relative to the average of the last half of the 19th century. When I look at this, I think, okay, well, I was born in 1975. I'm giving away my age here. And from the end of the 19th century to when I was born in 1975, so 75 years, global temperatures had increased by about 0.1 or 0.2 degrees Celsius. Since I was born in the last 50 years, they've rocketed up by another 1.3 degrees Celsius. I have a 5-year-old daughter. She was born in 2020. Even since then, global temperatures have increased by more than they did in the 75 years that started the 20th century. Many of us will be familiar with the Paris Climate Agreement, which was signed in 2016. This is where world governments signed up to reducing carbon emissions to the point where global warming will be kept well below 2 degrees Celsius of warming and preferably below 1.5 degrees Celsius of warming. 2024 was the first year that we already breached that 1.5 degrees Celsius warming threshold. So things are not going very well. And so what I'm going to do today is talk about what the challenges are and hopefully also appeal to a bit of optimism about some of the things that we can do and some of the things that we're doing at the Heat and Health Research Centre alongside many of our colleagues, both domestically and internationally, as we're facing a warming climate. So we talk a lot about mean global temperatures, but the challenge when it comes to heat stress and health are the extremes. So these are some examples of some high-profile heat waves that have taken place in different regions across the world: Europe, India, Pakistan. In the United States, back in 2024, a third of the US population were under a heat advisory, ordered to stay indoors to prevent the negative effects of extreme heat. When it comes to death, so the ultimate health impact, the WHO estimates that heat waves are responsible for more than 500,000 deaths every year. And if we think about that in terms of the change with global warming, this is a 60% increase since the 1990s. So 500,000 deaths every year due to extreme heat. Now, a lot of people then say, well, we've always had heat waves. We had heat waves in the 90s. I talk a lot about the Chicago heat wave in 1995. That was responsible for 780 deaths on that particular period. So it's important to think about this in the context of climate change. How much of these, or how many of these heat-related deaths can be attributable to human-induced climate change? And this is a really nice study that was published in Nature Climate Change in 2021 that illustrates this quite nicely. So conservatively, about 40% of heat-related deaths worldwide can be directly attributed to human-induced climate change. You'll see that Australia is about the global average, about 40%. But if we look in regions such as South America, for example, the impacts are much, much greater. So this is a clear link between global warming, climate change, more heat-related deaths. And this demonstrates that there's a lot of work that needs to be done. But we talk about heat-related deaths as though that's all we're actually concerned about. But I like to think about heat-related health impacts as being an iceberg. This is not a new analogy, but I'm going to go with it. And so what we see above the waterline, the tip of the iceberg, are the things that we count within our health system. We count deaths, and we can count hospitalizations. But there's a variety of other heat-related health impacts that impact people every day, impact societies every day, impact our economy, that are below the surface. And we're starting to understand with more detail what those impacts look like and how insidious this threat actually is. So we've been looking over the last 5 years at the way in which extreme heat and hot weather impacts human health and well-being in a variety of different ways across the human lifespan. I won't have enough time to go into all of the detail here, but what we know from epidemiologists is that extreme heat exposure during pregnancy results in an increased risk of stillbirth and premature delivery. That's been replicated in many countries across the world, including here in Australia. Children studying in hot schools have reduced educational outcomes that then have knock-on effects to their prosperity down the line. The risk of exertional heat illness in children is exacerbated by changes in their morphology and their physiology. The impact of extreme heat on the Australian economy in terms of lost productivity is estimated to be more than $8 billion a year. That exceeds $2 trillion a year globally. And as we look at the old age part of the lifespan, we know that age-related decrements in the ability to sweat increases the risk of negative health outcomes during extreme heat events. These then are coupled with the presence of other chronic diseases such as cardiovascular disease, renal disease, diabetes, to then multiply the risk of people that are exposed to these particular conditions. When we're thinking about solutions, we need to think in a systems way. We need to think about the way in which we can provide sustainable cooling for the people who need it the most without threatening the frail energy infrastructure that is present in many countries. We need to think about the way in which extreme heat is interacting with other features of our environment that are aggravated by climate change, such as poor air quality. As Ken mentioned in his opening remarks, there's an area of research which we're contributing to, which is looking at the limits of human survival due to heat stress with climate change. The downstream consequences of certain regions being uninhabitable at certain times of the year means that it serves as a catalyst for conflict and mass migration. We're also starting to look at interactions between extreme heat and the increased risk of mosquito-borne diseases and waterborne diseases. which are very, very prevalent during heat dome instances in places like India and Pakistan. So I'm director of the Heat and Health Research Centre at the University of Sydney, and we have 5 priority research themes that we're using to try to tackle some of these problems. We were established in 2022. We have a theme leader that leads each of these research themes, supported by a senior mentor. And we're focusing our efforts right now on maternal and child health, physical activity, sport and occupational health, aging and chronic diseases, landscapes in the built environment, and humanitarian settings. And below each of those priority research themes, you can see some dot points that are examples of some of the projects that we're currently working on together, either internally and with our collaborators internationally. Nested within the Heat and Health Research Centre, we have a facility called the Thermal Ergonomics Laboratory. It's based on the top floor of the beautiful new Susan Wakel Health Building, which is on main campus in Camperdown. And within this chamber, we have the capacity to simulate any heat wave of the past. We can go into the weather records and examine the most severe extreme heat events that had the biggest impact on human health. We can extract the meteorological records, define what the temperature was, what the concurrent humidity was, and recreate those conditions in the chamber and expose human participants, under careful medical supervision, of course, to these conditions to get a better understanding of what the effects are and what can be done to increase the resilience of people who are exposed to these conditions. Often people who don't have access to air conditioning, people who are living in low resource environments. Another really exciting aspect of this facility is that we have the capacity to also simulate the heat waves of the future. So we work with climate scientists to understand what the heat waves of the future will look like with different carbon emission scenarios. And then we can create those different versions of future realities now and demonstrate what the impacts are on human biomarkers of human health, also the capacity to conduct activities that we take for granted right now, and use that as an advocacy tool to understand what the impacts of the decisions that we make today are going to be before it's too late. So for today's talk, I'm going to focus on trying to address 2 primary questions. The first one seems like an obvious one, but it's pretty complicated. How hot is too hot? And the second one focuses on solutions. What can be done to reduce heat health risk of the most vulnerable as the planet continues to warm? So I'll get into the first question first. Before I go any further, though, I want to lay out a conceptual framework with which we use to address this particular question. The first thing that's really important to understand is that as a hazard, as a heat hazard, temperature is not the only environmental parameter that defines a human heat stress environment. So an answer to how hot is too hot, if you answer that with an ambient temperature, it basically makes no sense. So that's the first thing, hopefully, that everybody can take away from today's talk. The reason is that the way in which heat stress impacts human health is that it's moderated by other features of the thermal environment, most notably humidity. So we'll all be familiar with, if it's 35 degrees Celsius, if it's dry versus humid, it's a very, very different experience. That's because ambient moisture in the air prevents the sweat that we secrete from evaporating from the skin surface. It therefore doesn't liberate any heat and doesn't cool us down. So ambient temperature, which is measured in the shade, humidity, mean radiant temperature, which is a characteristic of the environment that takes into account direct thermal radiation through electromagnetic rays, either directly from the sun or from reflected surfaces. And then this is also further modified by air velocity. So we've got 4 environmental parameters that define a human thermal environment. But that's just the weather. And the problem is not the hot weather, it's the hot person in the hot environment. And so there are 2 personal parameters that define a human heat stress environment as well. What you're doing, so how much heat you're generating inside the body, and what you're wearing, because clothing serves as a barrier to heat transfer to the environment. And then the level of exposure based on your activity, features of the built environment which aggravate the level of hazard and exposure. And then down from the exposure, we have the resultant physiological heat strain. Now, this is a really important aspect of this conceptual framework because the health impacts flow down from this physiological heat strain. People get exertional heat illness or heat stroke because of an increase in core body temperature. So advanced hypothermia accompanied by systemic inflammatory response syndrome. People with cardiovascular disease, they're actually most at risk during extreme heat events, but they don't get hospitalized typically with heat stroke. They get hospitalized due to having a catastrophic cardiovascular event. And that catastrophic cardiovascular event comes about physiologically because of the way in which the body is trying to defend body temperature rather than an inability to defend body temperature. So cardiac strain is a very important component of that particular equation. And then the level of dehydration is also an important consideration because that can lead to an increased risk of kidney injury in people with acute kidney disease, or it can aggravate the risk of thermal strain and cardiovascular strain as well. So that's this flow of our conceptual framework. But the thing is then there are opportunities to intervene. We can change the weather, which is what climate change mitigation is about. We can plan our cities a little better, which might alter exposure. But there's other modifiers here as well. First of all, personal characteristics. An individual's age, what their health status is, if they're on certain types of medication, what their lifestyle are. These personal characteristics can modify really quite profoundly the level of heat strain for a given combination of hazard and exposure, and or they can modify the risk of a negative health outcome associated with the given level of heat strain that occurs. And then from a behavior perspective, there are things that we can do in the community to increase heat resilience. Behavior can be taken to reduce exposure. So despite the hot weather, we can reduce the exposure, which then reduces the heat strain and reduces the health risks. We can also use behavior to modify the heat strain for a given exposure as well. So that's the conceptual framework which we follow when we're trying to answer this question in terms of how hot is too hot and also what can be done to reduce heat stress risk. I just want to quickly lean in a little bit to what's going on physiologically. As I mentioned on the previous slide, people quite tempted to think that people are just getting hospitalized because of heat stroke. In fact, around about 20% of hospitalizations or deaths during extreme heat events are due to heat stroke. The vast majority of hospitalizations are due to cardiovascular complications. And the way in which that arises is not because of a critical rise in core temperature, it's because of the redistribution of blood from the body core towards the skin surface, challenges blood pressure. And in order to maintain central blood pressure, we have to increase our cardiac output. Venous filling pressure is typically reduced, therefore heart rate has to go up. The amount of work that left ventricle has to do increases dramatically, and that increases the risk of a catastrophic cardiovascular event if somebody has an underlying cardiovascular disease. Renal collapse arises by the pathway of dehydration, which again is not necessarily driven by critical rise in core temperature. Heat stroke is driven by a critical rise in core temperature, but the mechanism often surprises people. We have very high internal body temperatures, might reach 41 degrees Celsius. But then we start having an increase in permeability of the gut. You then have a translocation of bacteria from inside the gut to the bloodstream that then sets off a cascade of responses which results in systemic inflammatory response syndrome, mass coagulation around the body, and death. Like my old PhD supervisor used to say, you can't uncook an egg. Except some clever folks at Flinders University actually try to figure out how to uncook an egg, which is kind of messed up that analogy, but never mind. It was pretty grim, right? Got to throw a little bit of humor in there. Okay, so how hot is too hot? I've defined the hazard based on 4 environmental parameters. And in this particular case, for the sake of simplicity, let's assume the person is indoors and sheltered. So no radiation, additional radiation, and no additional or modified airflow. So we're left with 2 parameters that we want to be looking at in terms of the hazard: ambient temperature and humidity. If we look at the way in which the human body thermoregulates, it's really an energy balance equation. We generate heat inside the body. Right now, we've probably got about, 3,000 watts of heat production in this room, simply from living. And so we've got to get rid of that heat at the individual level to prevent overheating. And the way in which we do that is through sensible heat exchange with the environment, which is driven by a temperature difference between the outside surface of the body and the surrounding environment, and evaporation, which is augmented by the secretion of sweat from eccrine sweat glands. The environmental parameters that define those, if we have an imbalance between heat production and heat loss, we store heat inside the body and body temperature goes up. And eventually we might experience heat stroke. The environmental parameters that define sensible heat loss is ambient temperature. And when we fully maximally vasodilate, our skin temperature maxes out at around about 35 degrees Celsius. So the theory goes. So once air temperature reaches 35 degrees Celsius, there's no sensible heat loss. Therefore, the only way in which humans can physiologically keep cool when we're exposed to 35 degrees Celsius or warmer is through the secretion and subsequent evaporation of sweat. But if we have got so much humidity in the environment that there's no vapor pressure gradient between the skin surface and the environment anymore, we no longer have any evaporative heat loss. So we're generating heat inside the body. All that heat is being stored inside the body because we're effectively an adiabatic system. And over a 6-hour period, the amount of heat stored inside the body is sufficient to assure death by heat stroke. So this gave rise to this theory that the limits of human survival due to heat stress is at a 35 degrees Celsius wet bulb temperature threshold. So this is 100% relative humidity at 35 degrees Celsius, but it can be a bunch of other combinations of temperature and humidity that yield to the same wet bulb temperature. And this model was popularized by Steve Sherwood, who's based at UNSW, and his colleague Matt Huber, who's at Purdue University, back in 2010. And since then, this was elegant in its simplicity, was really, really important for putting humidity on the map in terms of the way in which we think about extreme heat and climate change impacting future human survivability. However, I'm a physiologist, and we do biophysical modeling at the whole body level. And when you look at that model, you realize that there's room for improvement. This model assumes an infinite ability to produce sweat. It also doesn't necessarily have physiologically relevant thresholds for core temperature rises that will result in heat stroke. So back in 2023, we wanted to reassess this model and basically build on Steve and Matt's work to then create a version that is modified based on human physiology and biophysics. So this was Steve's model, the 35 degrees Celsius wet bulb temperature threshold. So it can be made up of different combinations of temperature and humidity. If you're in the red and you're exposed to those conditions for 6 hours, you die. If you're in the green, you're okay. That was where we were at about 3 or 4 years ago. But when we integrate the limits of human physiology, particularly the ability to sweat at very hot conditions, we max out, if we're fully heat acclimated, at around about 2 liters of sweat per hour. Then what we find is that those limits are actually cooler and drier than we previously thought. And this is for a young, fit, healthy, fully heat acclimated, in the shade, nude person. If we then take into account human aging and these age-related decrements in the ability to sweat due to a reduced sensitivity to acetylcholine, which is the neurotransmitter that's responsible for sweating, you could probably guess what happens next. This person's still nude, by the way, so. These limits become much more modest than we previously thought. So the area in the yellow are the combination of conditions that we previously thought were okay, but now when we take account for the limits of human physiology, we actually think that they will not be okay. And so we're working with climate scientists now to understand where do those values fit. But this is still a model, and so there are questions around, well, how well does it stand up to the test of things that happen in the real world? So with Ken and the lethal humidity team, we published a paper back at the start of this year in Nature Climate Change, which took a microscope a little bit to the 2024 Hajj pilgrimage disaster. And one thing I want to say up front is that the people who are in charge of managing heat-related risks at the Hajj pilgrimage do an absolutely tremendous job. They do all they can to try to reduce the risks, but the threat is so great that even with the best efforts, these disasters still happen. So if you cast your mind back to the Hajj pilgrimage last year, there were 1,300 heat-related deaths over the course of a couple of weeks. And so what we did with the Mindaru team is we took our models that I just presented on the previous slide and then said, okay, well, how did those environmental conditions that people experience at the Hajj pilgrimage map on to those new thresholds. And what we actually find is that a lot of the much hotter and more humid conditions actually exceeded the thresholds that are outlined in our model. But what you'll see is the 35 degrees Celsius wet bulb temperature line at the top there, and these conditions are nowhere near that, yet 1,300 people died. So what we think is that we presented in this is that this is potentially early evidence of, I guess, an epidemiological support for the veracity of this new model. But again, these are models, and we're limited by the data that we have available for validating it. So we've undertaken some work over the past couple of years, which we were fortunate enough to have profiled in Nature last year. The data is still not out, but I'm going to present them today, where we're doing some work looking at trying to understand in human participants what are the limits of human survival with heat stress. And this work is led by my postdoc, Jem Cheng, who's funded by the Canadian Institutes of Health Research. So what we wanted to do was actually use our climate chamber to assess parts of the new model, but before doing so, we wanted to look at the way in which the old 35 degrees Celsius wet bulb temperature model performed. And so what Jem did is that she recruited 27 human participants, fully heat acclimated them for 7 consecutive days, and then exposed them to 3 combinations of temperature and humidity that yield a 35 degrees Celsius wet bulb temperature for up to 3 hours. So 38 degrees Celsius, 81% humidity, 46 degrees Celsius, 46% humidity, and 54 degrees Celsius and 26% humidity. And our hypothesis is that if our new model is potentially correct, then we would expect our human participants to respond differently to each of those 35 degrees Celsius wet bulb temperature conditions. Because the difference between the 35 degrees Celsius wet bulb threshold and the new model becomes greater as you go to a higher temperature. So that yellow wedge gets wider. And this is exactly what we saw. We take our participants up to a core temperature of 39 degrees Celsius. We can then use modeling to project their core temperature to a heat stroke core temperature of 40 degrees Celsius. This is the survival curve of all of our participants in the 38 degrees Celsius, 81% humidity condition. And what we find is that is 50% survival after 7.6 hours. So that's longer than the 6-hour exposure that was offered by Sherwood and Huber. But when we go to the 46 degrees Celsius, 46% relative humidity condition, we see that the survival probability dramatically reduces. So from 7.6 hours to 50% surviving for 4.9 hours. And then when we get to the 54 degrees Celsius and 26% humidity, this goes down to 3.7 hours. So different human responses to the same 35 degrees Celsius wet bulb temperature. The reason is that at the higher temperature, despite it being the same wet bulb temperature, the limitation is now human physiology. It's your ability to secrete sweat in the first place that is reducing your ability to keep cool, rather than the climate itself preventing that sweat from evaporating. So in easy terms, the level of lethal humidity is different depending on the ambient temperature and depending on age. And this work is ongoing, and we'll be following up with an elderly cohort soon as well. But one of the things I tried to emphasize in the first part of my talk is that it's not just core temperature that we should be worried about. We should be worried about a bunch of other things that are going to be affecting people's well-being and potentially their ability to survive extreme heat and humidity. And so I wanted to share these data with you as well. So because obviously we have ethics to do these studies, it's carefully clinically supervised, but participants can withdraw at any stage during these trials. And what we found is that there was a different number of participants that wanted to pull out because of heat-related health symptoms, depending on what conditions made up that 35 degrees Celsius wet bulb temperature. Almost 3 in 10 participants in the 54 degrees Celsius condition wanted to withdraw because of heat-related health symptoms. So not only are they getting hotter, they're also having earlier onset and more severe heat-related health symptoms. Another thing that is a really interesting outcome from this work is that the whole 35 degrees Celsius wet bulb temperature model was predicated on the notion that human skin temperature maxes out at 35 degrees Celsius when you're exposed to these types of conditions. And we carefully mapped, using infrared thermography, human surface temperatures throughout all of these trials. And we're recording skin temperatures at levels that we've never, ever seen before. So 39 degrees Celsius, in some cases 40 degrees Celsius skin temperature. Now that's beneficial from the perspective of heat transfer, because it's increasing that gradient to try to get rid of heat to the surrounding environment. It increases the maximum vapor pressure gradient that you get as well of the skin, because that's tied to skin temperature as well as sweating. But this also induces an enormous cardiovascular strain. When you're heating the skin to these types of levels, the vasodilation is maximal, redistribution of blood is enormous, and the amount of load that's on the heart in order to maintain blood pressure is really, really quite challenging. Now, for young, healthy people, it's not an issue, but I just want to quickly share with you a study that was done by my good colleague and friend, Daniel Gagnon, who's at the University of Montreal. He's at the Montreal Heart Institute. And so Hadiatou Barry, who was his PhD student, she's just doing a postdoc with us now, what they did is do some functional imaging of older individuals with cardiovascular disease and passively heat them during those maneuvers. And what they found is that with core temperature increases as little as 0.5 degrees Celsius, if an individual had coronary artery disease, it was sufficient to change cardiac work, increase blood flow, and increase in cardiac ischemia in these patients. And so across all of their participants, they found ischemia occurring in 35% of their participants. This is ischemia that wasn't happening when they're at rest, but when they're heating, they're just still. They're not doing any exercise. They're just heating them. And we've seen 1 in 3 participants experiencing cardiac ischemia, which then gives us more information for why cardiac outcomes are so negative during extreme heat events. So that work's ongoing, and we're pretty excited about it. But I just want to finish off by talking a bit about the work that we're doing looking at solutions. So there are lots of opportunities to intervene along something we've coined the heat cascade. So you have hot weather, and then there are features of the landscape or urban environment that we can modify to reduce the hazard that people are exposed to. We can introduce green infrastructure, blue infrastructure. We can think about the ways in which we plan our roadways, our buildings. So that's an urban planning intervention. Then we get down to the built environment, the building level. We can change the way in which buildings are designed through changes in housing codes by having a minimum requirement for insulation, minimum requirement for glazing, thinking about more carefully about the materials that are being used to construct houses. Western Sydney is obviously an excellent example where you've got poor housing stock in a very, very hot part of the world, which then aggravates heat exposure, often for people who are vulnerable because of the presence of other chronic diseases. And then there are activities that we can do at the individual level, and I'll just spend a bit of time talking about this. Very, very simple, accessible interventions that people can use at scale, but they're simple by necessity. Because keep in mind that the people who are most at risk are those who live in the lowest resource environments imaginable. It's be all very good to develop a new cool cooling vest or something like this, but that's going to be expensive and it's not scalable. We're looking at simple strategies that we can scale internationally to ultimately reduce the individual level heat strain that is responsible for heat-related health impacts. So back to the thermal ergonomics laboratory. As I mentioned before, we simulate these different types of heat waves, and we measure biomarkers that align with the different physiological heat strain parameters that define heat stress risk. We measure core temperature to understand what the level of thermal strain is. We measure the level of dehydration. We measure cardiac function, and we measure kidney function. And we also we just finished a study simulating a ready-made garment factory in Bangladesh in the lab. So we also look at work productivity in that particular case as well. So we have all of these physiological biomarkers that give us an understanding of the way in which people are responding to these conditions, and also gives us an idea of which type of interventions are most effective at reducing that physiological heat strain. And the answers are likely different depending on the type of heat wave, but also on the type of person. So we recruit human participants of a variety of different physiological profiles. We've had people as old as 90 years old in our lab, people with heart disease, people with multiple sclerosis. We've got a study that's funded by Wellcome, which is recently just getting underway, looking at pregnant women, we have kids. So lots of different profiles that we bring in, try to answer the questions for these most vulnerable groups. But the principles are the same. So back in 2021, I had the privilege of co-chairing the first ever Lancet series on heat and health. And that gave us an opportunity to gather up all of the information and summarize the physiological work that we'd done to date, and as some of our colleagues had done, where we simulate these heat waves and try to systematically understand what type of strategies, low resource, sustainable strategies work for reducing different markers of physiological heat strain, and what the limits and caveats are as well. And an important part of this work is then the translation of, basically you've got the infographic that we generated with the Lancet on the left. But there's a lot of information in there, and how do we then communicate that information to people in an accessible way so they can act upon it? That was in 2021. We've been building on the evidence base since. Probably the most prominent is this study that we published at the end of 2024, which is where we simulated two types of heat waves, and we recruited elderly participants with coronary artery disease. We exposed them to two types of simulated heat waves, a 38 degrees Celsius and 60% relative humidity heat wave, which is analogous to the Chicago heat wave in 1995, and then a very hot and dry extreme heat event, which is analogous to the Melbourne heat wave in 2009. And the question that this study, this is the clinical trial, the question that we were trying to answer with this is, in the most heat vulnerable, if they're elderly, if they have heart disease, what type of low resource cooling strategy should these individuals be using to reduce the amount of work their heart has to do because of the heat? Because that's the thing that is responsible for killing them. And so, again, these are very, very simple strategies. We're looking at moving air with fans, and there's a lot of controversy around when you should and shouldn't use fans. I can get into that later on if anybody's interested. But whether you should be wetting the skin at the same time as using a fan or just wetting the skin. And the findings were quite surprising. So if we start on the left, the hot, humid heat wave, what we find is actually rate pressure product, which is our primary outcome for this study, that is significantly reduced to physiologically significant levels with all three of those interventions. And the finding related to fan use, which is in the bottom left-hand corner, where it shows it reduces rate pressure product, that's really important because up until we persuaded the WHO to change their guidelines, the WHO used to say that you shouldn't use a fan above 35 degrees Celsius. And what we've now got in the most heat vulnerable people show that is simply not true, and they should be advised. However, in very hot, dry conditions, think about this as being a fan-forced oven. Fan-forced oven. A convective oven. So think about being in an oven where it's very hot and very dry, and you're now moving air across the skin. You're aggravating heat gain via sensible heat transfer because you're increasing the convective heat transfer coefficient, adding more dry heat to the body. It's very dry, so all the sweat that you secrete evaporates anyway. So you're adding extra heat energy to the system, but you're not extracting any extra heat via latent heat exchange. And so what we found is that under these particular conditions, it would be catastrophic if people start using fans in these conditions. We found a doubling of rate pressure product. We've just published the secondary outcomes from the study. It was accepted yesterday. We found a tripling at the rate at which people heated up using a fan versus doing nothing. And they double the rate at which they dehydrate. So there's clearly this environmental threshold above which you kind of get this paradoxical effect where the intervention that people are so used to using actually makes things far, far worse. What's really important about this is that these people couldn't tell. They couldn't tell that they were getting hotter. They couldn't tell that their heart was having to do more work. So the question is, how do we get this information into the hands of the people that need it the most? So we work closely with the World Health Organization. I'm really proud to say that we've managed to persuade the World Health Organization to change official policy on personal cooling strategies in May 2024. It remained the same since the late 90s. So that was a really big win for us. We were really excited about that. But we work very closely with other health organizations. Domestically, I work with New South Wales Health and also the Department of Health Victoria to harmonize heat health messaging across the two states to ensure that our research findings were embedded in their recommendations. We've also worked with the Queensland government, GPs, and other organizations as well. Another exciting collaboration that we had is with the City of Phoenix, which was documented in this National Geographic article that was published a couple of years ago. And so the City of Phoenix, much like Melbourne, has a chief heat officer through a different mechanism. And they have it's the hottest city in the US. They have huge heat health impacts. And so we work with them to help fashion a public awareness education system to improve or provide the best available evidence for people who don't have air conditioning on very hot days on how to reduce their health risk. Now, we can't fully attribute our research to this, but what we can say is that the following year, they reported for the first time in 20 years, a reduction in heat-related deaths in 2024, and they hadn't done that for 20 years. So that was a really nice outcome. We've also partnered with Google. This is really exciting. So through the World Health Organization and the Red Cross, we partnered with Google to develop a new excessive heat alert. So this is an automatic push notification that goes to every person who has Google Chrome or Google Maps on their phone. If they're in a heat wave, they get this automatic notification, and in that notification are the outcomes of our research in terms of what they should be doing to reduce their risk. So I looked up the statistics. I think we have the potential to reach 74% of global internet users through this collaboration, which I think is like 4.18 billion people or something like this. It's a bit crazy. But a good question is, well, you've got the mechanism in place, but how do you know that people are using it? So we worked with Google to try to get some analytics from this tool. It was launched in August 2023. 2024 was the first full calendar year that the excess heat warning function was automatically embedded on these devices. And what we found is that if you compare user engagements with our excess heat function, so this means that they're tapping on the information that we're giving them, which is our research outcomes, we can compare that to search queries. And if you rank them, the only search query that exceeded the number of user interactions that we had in 2024 was the US election. We had more engagements than the Olympics and the Trump assassination attempt. So, finally, I'll just tell you about another tool that we're developing here in Australia. It's called the Heatwatch tool, which is recommended by the Queensland Government, New South Wales Health, and others. And so this gives people an opportunity to create a personal profile within the tool, which enables them to derive individual level heat stress risk scores. We give them a 7-day forecast. It's free to use. You can create multiple profiles, so not just for yourself, but for your granddad or for whoever. That was an important part of the co-design process of this. This was co-designed with 250 people in the community. And we also use it as a platform to push evidence-based advice. We're also working on developing this into a surveillance tool as well to get heat health information from the community. So that's a really exciting project that's under development. And finally, I'll finish off with something that we can all do if everybody has an air conditioner this coming summer. So one of the challenges with air conditioning is that it's very energy intensive. It's very expensive for people. So there's the Australian Council of Social Services did a survey of heat vulnerable people in Australia last year, and 68% of people that they interviewed had an air conditioner but don't want to use it on hot days because it's too expensive, especially with the current cost of living crisis or pressures at least, that we're all facing, but particularly these vulnerable communities. So we've got the accessibility, so cooling poverty, but we've also got the environmental impacts of air conditioning use. It's a prodigious greenhouse gas emitter, secondarily to the fact that we use fossil fuel power plants to generate the electricity that operates the air conditioning units. It also places an enormous amount of strain on the grid. So in the summer, when it's very, very hot, everybody's coming home from work, turning the air conditioning on at once, puts a lot of strain on the electricity grid to the point where there's a risk of rolling blackouts or brownouts. So you've got these real issues that we're facing with respect to air conditioning use. And so what we wanted to do was test an idea that encourages people to use their air conditioner less. But what we face is we know that only a very small segment of the society are going to do it out of their goodwill. We can't expect people at scale to sacrifice anything if they can afford the air conditioner. So the thing that drives air conditioning behavior, of course, is thermal discomfort. People feel uncomfortable, they feel too hot, they turn the air conditioner on to remain comfortable. So that's the primary driver. And so what we've done over the last 2 or 3 years is that we've pioneered, I suppose, something called a fan-first cooling strategy. And this was published in Lancet Planetary Health back in 2022. What we do with the fan-first cooling strategy is that we encourage people to move air first and chill it less. So what this means is that if we think about the way in which the air temperature will change throughout a typical hot day, it'll warm up at the start of the day, you'll then exceed what we call a thermal comfort threshold. This is actually a temperature, above which you actually feel thermally uncomfortable. And that's the driver for air conditioning use. But what we know is that, and then that's if you turn the air conditioner on, then you have a certain volume of air conditioning use, which requires a certain amount of energy and a certain amount of cost, has a certain greenhouse gas burden. But if we move the air in an internal environment with a simple intervention, such as a pedestal fan or a ceiling fan or something like this, you augment heat transfer via convection. You keep the person cooler and more comfortable despite the hotter environment. And so what this means is that you only start to feel uncomfortably warm at a warmer temperature. I was telling some people over lunch this, is that if I put you in a 26 degrees Celsius room and move the air, and then you compare it to this room here right now, which is still and probably 22 degrees Celsius, from a thermal sensation perspective, you would not be able to tell the difference because you are just as cool despite the warmer temperature. So if we embrace this and say, okay, well, I'm going to move air first more, I'm going to keep cooler and comfortable, I'm going to adjust my air conditioning thermostat set point to turn on cooling at a higher temperature. That means it turns on later in the day, it's not running as hard during the day, and it turns off early in the day. And the amount of energy that I need to power that air conditioner is actually quite a lot less. So then the question that we wanted to ask in this study was, well, if everybody in Australia did this, what kind of benefits would we get? Would it be negligible? Would it be great? Who knows? So what we found is that electricity consumption for air conditioning use, which is the #1 line item on most people's electricity bill in the summer, would be reduced conservatively by about 70%, beg your pardon. So a 70% reduction in electricity consumption due to from your air conditioning, yet you feel just as cool and just as comfortable. This also has environmental benefits. Some people might be familiar with this. It's called the greenhouse gas abatement cost curve. The best thing we could do to date was when everybody switched from incandescent lighting to LED lighting. When I say the best thing we can do to date, the cost of an intervention versus the benefit that we get from reducing greenhouse gas emissions. The best thing that we've done to date was when everyone switched their lighting. Everybody probably remembers that. It was good for the environment. Our sustainability experts that participated in this study, led by Manfred Lenson and Aranima Malik, estimate that this fan-first cooling strategy is even better than that. The next question is, how scalable is it, and what are the behavioral barriers to everybody adopting this intervention? Because it can really make a difference. I'll finish off there. If anybody's interested in learning more about our work, we worked with the BBC last year to create this short documentary. You can get the QR code and access it, but happy to take any questions. Thank you very much.
So, Ollie, thanks. That was a tour de force. I think it's really chastening to think how little we think about the health impacts of climate change, despite the fact we're experiencing it. To hear it described like this, but to see the fact that you're doing this groundbreaking work to try and solve it, and start to solve it, is really impressive. What I encourage all of you guys to do is think about how these temperatures and these physiological changes, perhaps extended over more time, might impact the systems you work on. And do we really understand the deeper implications of this over and above the very extreme conditions you're talking about? But I'll shut up. And questions, I'm sure there's a lot. Yep.
Thank you so much for that fascinating talk. I had a couple of questions. The first is, I'm more interested in the sex differences, how an individual responds to heat based on their sex. And secondly, over the years, if we compare, say, 1900s or something, has the tolerance to heat increased or decreased? Yeah. So if you were to do those survival studies in 1900s, say, would you get different data?
Thank you. Not the first time I've been asked these questions, so thank you. So sex differences, the primary sex difference in the heat is what we call the maximum evaporative capacity. So under certain climates, the amount of sweat that can be secreted by each sweat gland, so the average sweat gland output, is lower in females versus males. We think it's due to a slightly different peripheral sensitivity to acetylcholine, but it's mainly morphological in terms of the actual sweat. So there are colleagues of mine that actually, they do biopsies, they look at the sweat gland, and the sweat glands are smaller. Now, under most climates, it's not a problem. If it's submaximal sweat rates, women sweat exactly the same as men. But when you get to these very severe conditions, particularly in dry climates, then there are going to be some differences. The study that we've done, that GEM is leading, looking at the 35 degrees Celsius wet bulb temperature limits, we powered that to look at a sex difference. And our preliminary analysis, we've got to look at it a little bit more, but we didn't see anything. The sex interaction was P equals 0.32. So I think that from a physiological perspective, and also from a morphological perspective, the differences between men and women are actually quite marginal. Where the real difference is and where work really needs to be focused, in my mind, and we're doing some of this ourselves, are two conditions that are unique to females. The first is pregnancy, and the other one is menopause. And so, like I said, I think I mentioned that we've got a new funded project looking at environmental limits for women during pregnancy and throughout pregnancy as well. So maybe I can come back and talk about those data when we have them in a few years' time. In terms of adaptation, this is a common question. So humans are profoundly able to adapt physiologically to the heat. We have a reduction in our resting core temperature, about 0.4 degrees Celsius. Our plasma volume expands a lot, so it reduces the cardiovascular strain. Maximum sweat rates go up, and other factors. Our sensitivity, so we start sweating sooner as well. But they're induced with acute heat exposure. So if you came back to Sydney with me and we exposed you to our climate chamber for 2 hours a day for 7 consecutive days and got you to run on a treadmill, in a week's time, you'll be fully heat acclimated. But then you'd come back here and you wouldn't do it, and then 7 days later, it would all go away. So they're very acute adaptations that we get. From a longer-term adaptation, there's very little literature to demonstrate that that's actually the case. We're having this conversation at lunchtime. Probably from a regional perspective, morphology plays a bit of a role. Again, it's at the margins. But if we look at the way in which typical morphology of people who are in different climates, who evolved in different climates, are typically a little different. But again, the magnitude of effect is actually pretty small, much smaller than I think many of us assume.
Thank you. That was really interesting. Just in terms of intervention, you mentioned, and so pharmacological intervention, you mentioned sweating is mediated by acetylcholine.
Yeah.
So there are lots of drugs on the market that target cholinergic signaling. So can we use these sort of drugs to enhance our sweating and respond to the environment in that manner?
Right. So, thanks for that. So this is a big area that we're working in as well, looking at the pharmacological implications of medicines, medications from a thermoregulatory perspective. If you look at the World Health Organization heatwave guideline, they've got a full table, a huge full-page table of 11 different drug categories that tell us that this anticholinergics do this, antipsychotics do this, beta blockers do that, from a thermoregulatory perspective. Then about 5 years ago, we looked at that table and thought, well, wait a minute, there's no citations in this table. So then I had a really good PhD student of mine, Lily Hospers, who's just recently graduated. She did a systematic review. We published it in Lancet eClinical Medicine at the end of last year, where we did a systematic review and meta-analysis of all of the physiological data that supports or refutes the effect of these different types of medications on thermoregulatory responses. And what we found was very underwhelming. 4 of the 11 drug categories had some data supporting the negative impact, which are propagated by the WHO, of these drugs on thermoregulatory responses. But things like antihistamines, which we hear about all the time, there's a lot of data, and all of it shows there's no effect. And so I think it's one of these things where you have an anticholinergic. Wow, if it's an anticholinergic, that can't be good. it's blocking your sweating. But at the dosages that people take it, for the conditions that they have, the anticholinergic effect is actually not that large, or not large enough, in order to result in wildly exacerbated heat stress risk. We're undertaking a series, so we just set up a platform in my lab where we can systematically assess the impact of different prescription medications. We just finished our first clinical trial looking at amitriptyline, which is an anticholinergic. It's something called an ACB3. It's got anticholinergic burden 3, so that's the highest anticholinergic burden. We haven't unblinded the data yet. Data collection's done, but we haven't unblinded the data yet, so I don't know what's happening. But a lot more work needs to be done in that space. But if you're interested in that, I recommend checking out Lily's systematic review, because that outlines what we know at the moment, and we don't know a lot.
I'm going to ask the last one very quickly.
Sure.
So there are certain situations where older people are forced to do work in hot climates, economically in some parts of the world. But here, for example, when the CFA go out for bushfires, they rope up a lot of relatively old people in the district that I grew up in. Is there a place for predicting heat risk by measuring sweating as people get older, sweating rates? Is there enough variation between people to make that useful to inform risk? Yeah,
so we do a lot of work on models. So the first before I moved to Sydney, the first 8 years of my independent research career, we focused a lot on individual variation. Because if you have everybody here do exactly the same thing in the same environment, we'll all have different core temperatures, we'll all have different sweat rates. But we've now developed models to the point where we can actually describe about 80% of that individual variability. It's not just us, other people have been working, and we do a lot of collaborative work. So there are models available. But I think what the tension is that you have a lot of organizations that want to talk about hot weather. There's a workshop I might be going to in London in a couple of weeks' time. It's called the heat stress metric workshop, and they just want to talk about wet bulb temperature or WBGT or UTC, whatever it might be. But I think what they're missing is that the problem is the hot person in the hot environment. And so you need a model that integrates that physiology. Obviously, you need good environmental data, but you need to integrate the physiology, which then takes into account aging, takes into account medication, it takes into account sex, and so on, acclimatization. And these functions are well understood, and then we can use those models to better predict risk. So that's kind of what we're doing with the HeatWatch tool, is you giving people an opportunity to provide information so they get an individualized risk score and then act upon it.
Great. So, Ollie, thank you very much for coming down from Sydney to give us such a terrific
Pleasure.
talk.
Thank you for having me.
Thanks to the audience for coming.